adolescent health issues. So that was the concept. Why not to join hands and share all the perspectives of one particular area of adolescent health. For example, we have joined hands with NAD. We are trying to look into the depth of the neurodevelopmental issues from the neurodevelopmental specialist aspect perspective also. So this is how we can get and reach ourselves with the global knowledge of adolescent health issues that will surely help us handle those issues in a better way. So I'm so very pleased to have the NDD chapter with us today. And I'm very, very thankful to Dr. Lal and Dr. Zafar for, volunteering to be a part of today's webinar. So without wasting much time, I welcome you all once again, and I hand over to Dr. Shamik for the proceedings, further proceedings. Thank you once again.
Thank you, ma'am. Thank you for those wonderful words and for outlining what we are trying to achieve. We have indeed extremely blessed in all our endeavors to have Professor M.K.C. Nair to grace us with his presence. We are very honored to have him today as our chief guest. I will now call upon Professor M.K.C. Nair to please enlighten us with his thoughts and with his guidance.
Most respected Dr. Sushma Desai, Chairperson, all the senior members of Adolescent Health Academy and NDP chapter. It's a great honor for me to inaugurate this wonderful new idea that to involve all the specialties into adolescent or NDP issues. The first point I would like to say, I understand we are going to talk about adolescent ASD. Am I right?
Yes, sir. And all other types of NDDs, sir. Different types of NDDs.
Okay. But let's focus on ASD because that is the most common one. Now, if you look at
ASD celebration, celebrated ASD, specifically ASD awareness celebration is going on in
I know. Yeah. Okay. ASD, when it comes to, most of us are focusing on younger ASD children, some up to 6, some up to 12. But most people are trying to avoid the adolescent part and young adults. Why? To my understanding, the issue is when you have an adolescent, you are likely to meet 3 scenarios. Number 1, the severe most cases. For example, if you go to CMC Vellore, the ward, you will get all sort of children with self-biting, self-injurious behavior, and all psychiatric things. So the bigger group will have some other full-fledged picture of adolescence. That is one group. Then you may have ASD who was bad in the beginning, but slowly improving. But when it comes to educational issues, they still have some problems. So that needs support. That's all. And you have a third group emerging that is very small in number, but significant because they are the high functioning ASD. Why I'm saying this is because this high functioning ASD, if you miss them, then their only problem may be the social interaction. Otherwise, social communication, all other things they will be doing very well. So I think today we need to somehow discuss these 3 groups apart from many others. The other issue is we need to have some centers declared dedicated for adolescent NDDs, particularly adolescent NDDs and particularly ASD. That is something which we have to. Although when it comes to small children, I do not encourage all the therapists to fall into it. But in the adolescent thing, all our therapy friends are absolutely essential because they are well trained to do that. And this is a group of children. They are not so competent to look after small babies. But when it comes to adolescent, their training is absolutely all right. So I think we need to look at that. One other issue, probably the gynecologist involvement. Because all the NDDs, you are going to have problems with the gynecology issues. So gynecologists should, apart from psychiatrists, that is absolute essential. pediatric neurologists, and now most important, gynecologists. If you have a team like this, I think we'll be doing very, very well. Thank you. I declare this seminar series inaugurated. Thank you.
Thank you, sir. Thank you so very much for throwing light on the finer aspects of this partnership. We are also blessed today to have Dr. J. Stuteja. Dr. Sir, the field is yours now. Please throw a
Good
few
evening,
words.
Tuteja sir. Good evening. Good evening. We can't see you.
No, we can't.
I'm there. I'm seeing you.
But I can't see you.
He's there, sir.
How you cannot see me?
But you're like God.
No,
We
no,
know
no,
it is
no.
there. We know it is there, but we can't see. There's a problem. Okay, now I can see. Okay, thank you,
No,
sir.
thank you. Thank you, sir. Good evening to all, to my respected teacher, Dr. M.K.C. Nair, sir, chairperson, Sushma Desai, activist again of AHA now. And we had some little disturbed time, but now I think we are on the right path. It is all because due to the MKC effect. Because she is also thinking beyond what we can further do in adolescent health academy. So interdisciplinary, inter-chapter involvement, I think it will go a long way and will definitely benefit adolescent health academy and the adolescent of our country. Thank you very much.
Thank you, sir. Thank you for your
Thank you.
blessings, sir.
Thank you so much, sir, for your very, very kind words. We are also blessed to have Dr. Piyali Bhattacharya today, our chairperson-elect. Can I please call upon Dr. Piyali Bhattacharya to please bless this event?
Thank you, Shomi. Watching this story unfold today makes us all so happy. As I say, in Lucknow, we say hum, we don't say main. So this is like a hum feature, you know, we are partnering with others. It's an inter-chapter sort of a webinar. And a lot of people other than only AHA members would also be involved. So then it becomes from me and I to we. So that is what makes us so happy and blessed. Thank you, Sushma, for thinking about this and starting all this. Best
Thank you, ma'am.
wishes.
Thank you, ma'am.
Thank you so much, Sushma ji. And Piyali ji, I think so we will be carrying forward a lot of this onto next year. We are also extremely fortunate and blessed to have representation from the neurodevelopmental chapter. And before I proceed further, there has been a message of best wishes from Dr. Swati Bhave. She's a little indisposed and is unable to join us today, but her blessings and best wishes for this entire endeavor continues to be with us, and it is my duty to convey this to everyone who is attending this today. Thank you
to
so
ma'am.
much, ma'am.
Thank you. She's always a big support and a guide for AHA, entire AHA, not only myself. Thank you, ma'am.
And a huge round of applause and thanks to the neurodevelopmental chapter. The secretary of the neurodevelopmental chapter, Dr. Lal, is here today. May I please request Dr. Lal to please come on to the stage and share his thoughts on this particular initiative.
Welcome,
Thank
Dr.
you.
Lal.
Yeah, thank you, sir. Thank you, ma'am. Thank you, ma'am, for involving us in this particular chapter. I don't know what to say when it's actually a great privilege to be among the great doyens of adolescent pediatrics chapter in this particular webinar. And that too, along with my teacher, Professor Dr. M.K.C. sir, and our Samir Dalway over here, the backbone of our chapter. And then this particular concept of addressing the adolescent issues among the neurodevelopmental chapter is a very apt one as of today, because from our point of view, we are seeing small children and they are progressing on, and after that, what's happening? We have no idea. We are just left like we are just living like that in lurch. So this is one area which I think the neurodevelopmental chapter and the adolescent chapter should work forward in a very coherent and in a what do you call, in a way in which we can deliver the results. That's something which I'm actually very grateful to the chapter of the adolescent pediatrics, Dr. Sushma Desai ma'am, for bringing these two chapters together in this particular to address this particular pressing issue, which is actually the need of the hour. So we have done, of course, last year we have done one day full workshop on special needs adolescents, and many of them are currently panelists in this particular webinar also. Okay, maybe we will have more work to do, madam. We would wish that adolescent chapter and neurodevelopment chapter work together on developing or co-developing some modules or things like that for the benefit of the children and the speciality. Thank you,
Sure,
ma'am, for providing us with the
sure, sir.
opportunity.
Sure, sir. Looking forward to, sir.
Thank you,
Amen.
ma'am.
Thank you, Dr. Lal. This is just the beginning. We promise to collaborate because
Thank you, sir.
we will definitely look forward to working with all of you. Dr. Hema Bindu Singh has also joined us, our immediate past chairperson. May I please call upon Dr. Hema Bindu Singh to please say a
Welcome,
few
Hima
words.
ji.
Yeah.
Welcome, Hima ji.
Thank you, Sushma ji. Thank you, Shamik, Dr. Shamik. My respects to Dr. MKC Nair sir, Dr. Tuteja sir, and all seniors here, and my colleagues, Dr. Samir Delvai, and many others from the neurodevelopmental chapter. It's really heartening to see that adolescent chapter is coming up with interspeciality or webinars this year. And really, congratulations to you, Dr. Sushma. It is a great idea. And we have so much in common, neurodevelopmental and adolescent chapters. We talk about the science of development, the behavior of the adolescents. There's so much common, and we both these chapters can work together to understand the behavior of the adolescents and what are the strategies, what we can do together. And I think today the panel discussion and the topic selected and Chaya and everybody, I'm sure they will do a lot of this good insights will come out of this discussion and some strategies what we can do together. I hope this will be the some key messages which will come out from today's seminar, the webinar. Thank you once again. All the very best, and looking forward for the session today. Thank you.
Thank you, Hima ji.
Thank you so much, Dr. Hema Bindu Singh, for those very, very kind words and for constantly guiding us in our endeavors. So thank you very much to all my fellow office bearers of the Adolescent Health Academy, all our executive body members, especially the coordinators of this program, Dr. Swati Ghate and Dr. Deepa Janardhanan, who have worked tirelessly to make this dream come true. Thank you so much for joining us. Today's program will have an expert talk by Dr. Samir Dalwai on adolescent autistic spectrum disorder, what are the challenges and what are the opportunities which we will get in guiding them. It will be followed by a panel discussion on adolescents with neurodevelopmental disorders. What would be the pediatric practice perspective? That is, how we as pediatricians can help these children and what will be the timely referrals that can be done. I now hand over to my very good friend and the Joint Secretary of the Adolescent Health Academy, Dr. Prashant Karia, to formally introduce all the faculties who will be participating in today's webinar. Over to you, Prashant.
Yeah, thank you so much. And it's my real honor and privilege to introduce all the stalwarts. AHA Neurodevelopmental chapter is beginning with a new collaboration. And in this collaboration, to begin, we do have a panel discussion, which will be moderated by Dr. Chaya Prasad. She is a renowned developmental pediatrician, adolescent health expert, and child rights advocate.
Excuse me, Prashant. The first talk will be by Dr. Samir Dalwai.
Yeah, ma'am. I know, but I'll introduce Samir at the last.
Last? Okay.
Hello? Yeah.
Yeah.
Because before
No problem. Go ahead. Go ahead.
Yeah. With a vast experience in neurodevelopmental pediatrics, she has contributed significantly to national guidelines on autism, ADHD, and neurodevelopmental disorder. She is the founder, clinical director of Asha Center, Chandigarh, and has had multiple leadership roles within IAP, including the national chairperson of the Women Wing. Her work strongly emphasizes early intervention, child protection, and empowering families. So, welcome, ma'am. We do have experts, Dr. P. Shivaraman sir, who is an experienced developmental pediatrician with decades of service in child health and early intervention. Based in Erode, he has been actively involved in pediatric care, academic teaching, and implementation of a newborn screening programs, including a hearing screening initiative. A former president of IAP Erode branch, a widely respected grassroots level contributor, and committed to a community pediatrics. Welcome, sir. We do have Dr. Navina Karthik with us. She is a consultant developmental behavioral pediatrician specialized in early intervention in high-risk follow-up infants. Known for her expertise in parent-mediated interventions, helping families implement practical home-based developmental strategies. Her work extended into adolescent care, focusing on life skills, emotional regulations, and transition planning for children with neurodevelopmental conditions, aiming to build independence and quality of life. Welcome, ma'am. We do have Dr. Swati Bhave, a pediatrician and adolescent health specialist and a clinical psychologist Swati Ghate, with extensive experience in developmental and mental health care. She serves as a joint director at Babylon's Newton Institute, Jaipur, and is deeply involved in academic training through IAP fellowship programs. A prolific academic contributor with over 70 citations, she has authored guidelines, edited textbooks, and created impactful awareness content, and also a national faculty and a master trainer in child and adolescent mental health. Welcome, ma'am. We do have Dr. Somashikar AR, a professor. Dr. Somashikar is a senior pediatric pulmonologist and adolescent care specialist from Ramaya Medical College with a distinguished academic and leadership career. He has served as the president of the IAP State Respiratory Chapter and held key positions in allergy and respiratory chapters at both state and national level. And as an editor and academic leader, he has contributed significantly to pediatric pulmonary literature and continued to shape child health policies and education. So with this, we do have a panel which is powerful blend of clinical expertise, academic excellence, and real-world experience, ensuring a holistic, practical, and forward-thinking discussion in adolescent neurodevelopmental care. And now, to introduce my dear friend, Dr. Samir. I thought I'll introduce Samir in a different way before his talk in his mnemonic Samir only. So this S stands for a service with impact, because service means he is a founder of a Horizon Developmental Clinic, which is actually taking care of our children with developmental challenges, and service because he's a recipient of Rajiv Gandhi Manav Seva Award in 2012. So his work reflects deep commitment to a child welfare at both clinical and national levels. I thought I will introduce S as a smart, but I think service is a better word. Though he's smart looking, but then service oriented is a better word. A stands for academic excellence and authority. I mean, with the plenty of degrees like MD, DCH, DNB, FCPS, FIAP, LLB, he actually combines the medical expertise with legal and policy understanding, and editor-in-chief of the IAP handbook, author of multiple national consensus guidelines, including the ASD, ADHD, specific learning disability, and many more, and help to shape standardized pediatric care across India. M stands for Master Leadership in Pediatrics. I mean, he has served as a national level as a treasurer and joint secretary of IAP, leading IAP to a greater heights. His leadership has influenced pediatric practice nationwide and contributed to the public health as a member of the Maharashtra Pediatric COVID Task Force, as well as in NCECD, he was one of the pioneering members. I stands for Innovation in Child Development. Like, as I said, he's a founder director of the New Horizons Child Development Center and introduced a path-breaking concept like the New Horizons theory of human engagement. Manushya Magnata, as he rightly said many a times. And R stands for a research, reach, or a recognition at many places. So with this, I introduce to us to today's first speaker, Dr. Samir Dalwai. Welcome, Samir Dalwai.
Thank you, Dr. Prashant, for that innovative way of introducing the speakers, especially Dr. Samir Bhai. And thank you so much for being with us, Prashant, despite all that busy schedule. Thank you, Prashant.
So we
Samir,
now,
bye.
yeah.
Yeah.
So we will now have the first talk on adolescent ASD challenges and opportunities by Dr. Samir Dalwai. The stage is all yours, Dr. Dalwai.
Thank you so much, my most respected teacher, teacher of teachers, Dr. MKC Nair, sir. Thank you for your gracious presence to begin with, not just today, but in our lives and all our learning journey, past, today, and future. So thank you so much. Also, this is a very auspicious beginning because this is the coming together of two streams, and this is something which is going to continue. So it truly says that the two chapters coming together, that is the chapter of neurodevelopmental pediatrics as well as the chapter of adolescence. I think what it signifies is the birth of a new journey that Sushma Ben, dear Dr. Sushma Desai ma'am, chairperson, and dear Dr. Shamik Ghosh, secretary of this chapter, have embarked upon. And now, once that there is a birth given to it, now the first stages of development, and hopefully across the whole year, the development will be so good that will end up with a perfect adolescence. So my best wishes to the
Thank you.
adolescence health chapter.
Thank you.
And
Thank you, sir.
wonderful work. Also, my regards to Dr. Ashok Banga sir, Dr. Tuteja sir, Dr. Arvind Sawant sir, Dr. Hima Binduji, Dr. Chaya, my dear friend, and my colleague, Dr. Shivram Raman, as well as Dr. Sudha Singh, my dear friend Rashutosh ji, and the chairpersons of the other chapter, the neurodevelopmental chapter, Dr. Zafar Minai, as well as Dr. Lal, the secretary, and all the office bearers. So thank you so much for this wonderful initiative. With this, I'd like to start with the presentation. Allow me to share my screen, please. टुडिया सर मैंने याद किया था थोड़ी देर पहले, शायद आप जस्ट ऑफ स्क्रीन थे. नमस्कार, प्रणाम. So thank you again for giving me this opportunity to talk about adolescence and autism. And I'm aware that there is a very distinguished panel of experts who are brilliant in both the topics. So I'm going to have more of an esoteric thinking and a reflection rather than a presentation as what was discussed. And we are going to look at the issue of adolescence and autism in terms of recognizing it, because sir, as it is made a brilliant point in the beginning, that very often we miss it. Understanding not the autism, but why we miss it till adolescence, the challenges and of course solutions we can discuss about at the end. So like I said in the beginning itself, you have a newborn child and a development, and you are going up to adolescence. And that's a wonderful bridge, madam, you have chosen to begin with. But the key issue is that they are not separate. They are part of the same journey since birth. And hence, just like a tree we see, and you see the roots are right from the birth. And hence, the roots of adolescent issues are always to be found since birth. And that is a point MKC and Nair sir made. Because change is the only constant, as we know. An adolescent is only a brain maturation phase period from childhood to adulthood. One moment. This is a plastic and dynamic processes since birth that drive towards adolescent brain development right from birth. But this creates flexibility that allows the brain over a period of time to refine itself, specialize, and sharpen its functions for specific demands. And may I say, get ready for adolescence when the other hormonal changes hit. And hence, it's very important also to recollect and remember that, as Confucius said, if one wants to run, one must learn to walk. If one wants to teach, one must learn. And to define the future, one must study the past. And hence, before we go to adolescence and to study and define adolescence, one must study the past. And that is right since the beginning of life. And hence, very often clinically in adolescence, it is actually an expression that is seen of a problem, if we may say so. It is not the beginning of the problem. Because again, like sir said, behavioral traits begin to get expressed in adolescence maybe for the first time, surprising us caregivers who did not expect these. Suddenly the child who was like ghar ka ladla, very doubtful son following the mother everywhere, suddenly starts showing these conduct issues. And even more important for physicians like us is it is a period of actually recognition. It's not the beginning, because these traits are always there, or they were milder or less troublesome or less obtrusive earlier. When parents say, बच्चा है, करता है, बाद में ठीक हो जाएगा. Surprising caregivers who did not see these earlier, though they were seeing it. And hence, it's like the ostrich approach that we see. And why is that important? Because adolescents are not independent units. They are not independent units. They are a work in progress from the perinatal period to adolescence. And just like we said, the way we groom them right from beginning, how we help the plant grow, and hence adolescence is the outcome, not the beginning, as we understand. And hence the question, dear friends, that we must ask ourselves, when an adolescent walks into our clinic and we were on the garb of looking at them in an adolescent clinic, and the parent recites or the child adolescent recites their complaints or their issues, the question is, can we analyze these complaints in real time in isolation, or do we understand that the roots of these complaints, it may be flowering now, but the roots of these complaints are in the process of child development right from the time of conception to right now. Otherwise, what do we end up doing? We have these wonderful charts that tell us, oh, adolescents will have rebellious attitude, wants to be independent, shows mood swings, decreased communication, refuses to do chores. And hence we must understand that these are nothing but these are symptoms of the problem, like fever, cough, cold, that they present to us with these complaints. But one must be very careful not to go on to give them paracetamol for fever or dextromethorphan for cough or domperidone for the vomiting, because what you see are symptoms. But please do not think that dealing with violent adolescent behavior, how do I deal with this aggressive behavior, how do I deal with this anxiety, these are symptoms. Let's not keep giving paracetamol in a case of malaria or typhoid, because for some time it may help, but not over a period of time. And hence targeting the symptoms and ignoring the root cause very often leads to lack of clarity in practically analyzing the adolescent's problems or advising remedy. And hence we see benefit for some time, but it is not a permanent outcome. Going back again, we know that early childhood determines later outcomes, and the UNICEF and WHO nurturing care framework, where all of us have worked so well in IAP, which tells us lack of nurturing care alters stress regulation, emotional development, etc., which has a long-term impact on brain development. So those friends who attended the ECD program said, oh, let's understand ECD so that we can prevent long-term impact. But those now, at the other end, now we are dealing with adolescents. This is the long-term impact that we are inheriting. And hence, nurturing matters more than nature, because epigenetics, not only the caregiving modifies gene expression, but that is the only thing that can be modified, because the genes cannot be modified. And let us remember hence that when it comes to adolescence, when the child hits adolescence with this background already in place and the hormonal changes kick in, it is not all adolescence. And hence, puberty doesn't cause the behavior, it amplifies pre-existing developmental inputs. With that, another aspect that we must be very concerned about in India, and especially people who have been the innovators and those who have been working ingeniously, Dr. M.K. Nair sir, Dr. Tuteja sir, Dr. Swati Bhave ma'am, they have understood the Indian psyche and the Indian situation. And otherwise, unfortunately, most of the so-called evidence-based data comes from weird settings, which actually stands for Western, educated, industrialized, rich, and democratic settings. This is a socio-cultural and a socio-economic mismatch in India. And hence, when it comes to especially mental health, we have to understand that the social environment and not the lab, the social environment is more important, because our adolescents face vastly different socio-familial pressures, structural inequalities, family expectations, school stress. And with this setting now, I would like to proceed to what is our experience in India. And as you can see in child developmental practice, right from early 2000s, from 2003 when we started, but started keeping records, you see a significant increase year on year in the number of children. This is the last 5 years data, and you can see the huge number of increase in the number of children. This is not to show my numbers, but it is to encourage all my colleagues, younger colleagues, not to make the same mistake that we did. Start collecting your data and recording it from right now. But if you look at a snapshot of adolescent health within our clinics, it's about 271, which is a very, very small number, which just still tells us that adolescent problems are not being recognized and being seriously taken for professional help. If you see, significantly, that I'll show in the next picture. And so this is a distribution across all the multi-centers that we have. But if you see the significant point here, the maximum children seen by us are in the 10 to 12 years age for the first time. And as the age increases, actually the numbers peter off, which says that as the children get older, either the parents don't feel this is something that needs help. Abhi to bacha hai, is age mein sab aise hi karte, everybody behaves like that, and they don't seek help. But it is the early years, even before pre-adolescence, 10 to 12 years, where they are still worried about these issues, complaints from school, not fitting in, that they do come to us. So we'll go to this case of a 13-year-old child born in Kolkata, is a first child of non-consanguineous parents. Birth history was uneventful. Motor milestones were age appropriate, but delays in social and communication domains. At 4 years, he had concerns about speech, aggression, difficulty with peer interaction, repetitive behaviors like hand flapping and stimming led to a neurological evaluation. He was diagnosed on DSM-5 criteria with assessment showing below average social functioning. Now see the fun what happens. Early intervention journey is intensive therapy, occupational therapy, 4 sessions per week, speech therapy, 1 or 2 sessions per week. Despite consistent intervention over the next 5 years, behavioral concerns such as aggression and self-injury persisted. Now, what do you do? Okay, now you go to a psychiatric. He starts medications, olanzapine and risperidone, which reduced but did not eliminate the symptoms, which again is a pointer that we've only been working on symptoms. Schooling remained a challenge. Initially, he went to a mainstream school with a shadow teacher. Later, transitioned to a special school. After 10 years, at 10 years of age, he relocated to another city. His intervention intensified further. Daily routine became highly structured. 6 hours of school, 2 hours of therapy, 2 hours of football, 2 hours of remedial education. Plus, the parents were made to start a sensory calming room at home. And during this period, behavioral problems continued. Further medications, including clonidine, haloperidol, aripiprazole, and melatonin. Sometimes depending on the doctor, sometimes depending on the mother, and sometimes now depending on the child's willingness to take it. And despite the appearance of a so-called comprehensive plan, because according to us, only these elements that are seen in the slide are all that is needed, the child's core difficulties remain unresolved. So what do you see at 12 years when he relocated to Mumbai? The same structured model was continued, but a sudden deterioration now that he hits adolescence, increased aggression, screaming episodes, self-injurious behavior, biting, hitting, difficulty managing at home and school. So the parents, now having done whatever was told to them, are now questioning what has gone wrong and are distressed. So at this stage, when we enrolled the child, we didn't focus on the symptoms, but on the underlying mechanisms. And the key clinical insight was a child's primary difficulty was not lack of skills, but impaired human engagement and social connection. And parental engagement was the key area we focused on, yes, even at 12 years. So the intervention shift was this sensory calming room, etc. was removed because he can't be in this calming room all over the world. No, you can't carry that room with you. The therapy load was reduced, school demands were modified. The mother was guided to engage the child in simple daily life activities at home and natural interactions. And of course, since the age was 12, father was encouraged to play interactive games with the child without focusing on rules or performance. And from skill training to life participation, from academic and remedial, we shifted to real life engagement and shared experiences. We reduce these repetitive, predictable tasks or pattern treatment, which happens in the therapies, and introduce dynamic, interactive, socially engaging activities, emphasis on co-regulation and interaction with people. And now over a period of 9 to 10 months, there is a reduction in aggression, self-injury, improved tolerance, able to adapt better, improvements in one-sided speech. He moves on to meaningful, purposeful communication and successfully overnight picnics, etc. with people. We'll go on to the second case now, which is a little different. 12-year-old male child, uneventful birth history, family history not significant. The complaints that he presented at 12 years are rigid routines, poor peer interactions, repetitive behaviors. And he had all these things which would, typically make us think about an OCD, rigidity, preference for specific ways, immediately cleaning hands after contact, social difficulties, limited peer interaction, poor eye contact, social anxiety dealing with different people, very selective about food, screams when expectations are unmet, problem with physical coordination, but very well performing academically. And this should give you the clue that if there is otherwise so much of anxiety, even the academics might have been affected. And hence, when you go back and take a detailed developmental history, you find very clearly that his motor milestones were very, very good, but he had delay in human behavioral learning and social communication and social behavior and social interaction. And hence, this is what again sir told us a few minutes back, and I immediately changed my slide. This is what is called high functioning autism. And what really helped this child was not training just on the academic skills or other issues, but helping him understand the basics of communication skills, the non-verbal communication, the social cues, helping him with the routine and structure, and emotional regulation, helping him to learn coping strategies from within the family with the parents rather than just in a clinic with us. Then helping him learn, deal with different people he was familiar with, families, uncles, aunts, cousins, and situations rather than only giving him advice in the school. And eventually, once he picks this up, then facilitating structured peer group activities, which help boost his self-esteem and confidence building. So the key point, my friends, is autism is certainly not a condition that develops in adolescence. So now the kind of clinical picture that we see in adolescence is one, a diagnosed ASD now in adolescence, either getting better or getting worse. And in fact, getting more diagnostic labels like OCD and antisocial personality disorder and anxiety and learning disability and depression. And each of these brings with it its own treatment and medication. Or you may see a missed ASD, which was missed earlier, and now in adolescence, you are realizing, oh, this was actually ASD. But very commonly, you see a wrongly diagnosed ASD, very commonly diagnosed as ADHD or LD, and now comes to an adolescence. And hence, very important to understand that the reason for this misdiagnosis is looking at the child and blaming the child and trying to find everything inside the child's brain instead of exploring the childhood, which is a mixture of the society and environment around the child. Why does this happen quickly? Because what parents notice are symptoms. My child has cough, cold, fever, and they come to you telling you that. Similarly, my child is hyperactive. My child wants to do the same thing again and again. He doesn't like change. But what is being offered are only symptomatic interventions. Oh, if he has hyperactivity, do this therapy. If he has a speech delay, do that therapy. If he has a reading problem, writing problem, do remedial therapy. In spite of all this, the child is not sitting in one place in the school. Hire a shadow teacher will sit on top of the child so that the child does not move here and there to disturb the other children. And hence, what parents notice are the symptoms, but what is being offered according to the Western guidelines are all these interventions. But after years of doing it, there is very limited real world improvement or outcomes. So, can we go beyond the Western model of symptomatic intervention? Can there be a model for India more in sync with our socio-cultural advantages? Because family, society, community, chachi, masi, bua, mami, these are our advantages. So at New Horizons, we came up with these two innovations across the last so many years. One is what we call the New Horizons Social Behavior Communication Sequence, which is nothing but the milestones for social communication domain. And also the New Horizons Theory of Human Engagement for Autism. What is it? It's very important and it's very helpful to understand that just like gross motor domain tells you there is head holding, rolling over, sitting, standing, walking. Similarly, we put down this because parents feel speech is an independent milestone in which you should start working. Mama bolo, say mama, say good morning. So directly working on the speech, what you end up getting is echolalia, which is pattern learning, but the child never has good conversation as you saw in the case. And hence it is very important to remember that the first milestone is not speech, but it is the child's preference for humans over objects in the first 1 or 2 months of life when he starts having eye contact due to this social engagement and he starts responding to name call. Once the brain starts getting organized synaptogenetically, then the child learns social behaviors. What does the mother do at home? What does the father do? For example, when the bell rings, the mother goes and opens the door. When the bell doesn't ring, she doesn't open the door. So the child learns from the observing the mother. What do humans do in different situations? When do I change my clothes? When do I not change my clothes? How do I go about my toilet? How do I go to my the bath? Where do I remove my clothes? Where do I not remove my clothes? These cannot be taught in the New Horizon Developmental Clinic or in adolescent clinic. These are only taught if the first milestone of observing people in the home, then the relatives, and gradually in the neighborhood, and only then comes the role of schools or clinics. As this develops in the first 8-9 months, by 10 months, 11 months, the child starts understanding that waving and pointing are not just motor movements of the parents, but they are communication or signals or messages, which is non-verbal communication. A good 1 year of developing these synaptogenesis to understand these 3 earlier milestones makes the child understand that the sound I am hearing is nothing but it is a message or a communication. And when sound becomes meaningful, we call it a word. So speech develops only after that. A good 2 years of verbal communication then makes the brain strong enough to see 3 lines or 4 lines or a circle drawn on a piece of paper and give it a sound. Oh, this is A. What you're seeing on paper is 3 lines visual, but you are giving it a sound A, and then you have APPLE, and then you have apple, so on and so forth. So the point is, unless the earlier milestone is mastered, like Illingworth told us, the subsequent milestones may be attempted but can never be mastered. So if you haven't mastered the first 3 milestones on the New Horizon sequence, if you only start with speech, the child may by heart it, but the child will not understand when to speak, when not to speak. And hence, what we said is, when it comes to autism, the theory of human engagement says that the first deviation in all these children is not the problem of speech, but it's a condition since birth where the child fails to connect, engage meaningfully with other humans, is too far engaged with objects and patterns. And hence, this poor human engagement makes the child fail to engage with people, leads to impaired social behavior and communication. Whereas excessive object engagement, child focuses on objects and patterns, leading to being a pattern copying master or a pattern ustad, leading to echolalia and repetitive behaviors. And I'm sure all of us have seen this video. I won't spend your time on it. But if you look at this chart that we published in Indian Journal of Practical Pediatrics, if the innate engagement with humans innately within the newborn child is present, if that innate engagement is normal, then the child will go on the milestone following the sequence and learning step by step via synaptogenesis and the environmental exposure towards normal social behavior and communication. But if the innate engagement with humans is deficient to begin with, then the child will have all this impaired social behavior, impaired non-verbal, impaired verbal, excessive focus on objects leading to pattern copying, leading to the restrictive repetitive behaviors, and hence the child will develop all these symptoms of autism. And hence we say that there is actually a road to autism, and that road is being increasingly resorted to, or children are being pushed on, because there is decreased availability of human engagement compared to 20-30 years back. And children born 30 years back, for thousands of years, though they had a little problem, little deficiency of innate engagement, they got it from the kaki, masi, bua, mami, mummy, daddy, grandmother, grandfather, and that kind of supplemented their little lack of innate engagement. Just like if somebody is born with a little deficient iron, you will add iron from outside and that tops up it up. But today there is decreased availability of human engagement, but what is worse, increased availability of objects and pattern, and that's where the screen, as well as all that shape sorting, color mapping, the blocks, the rings, actually is now worsening the child's innate trait of pattern learning. And hence, unfortunately, we must remember that DSM only tells us the final picture, the symptoms or the summation of the symptoms. It doesn't tell us where this problem begins, and hence we are reduced to only symptomatic offering of treatment, never being able to go to the root cause. And this is what is now being seen as this dangerous sleep, which I call from cradle to classroom. Today in the community, there is no exposure to family, neighborhood, no exposure to neighbors, which were essential components of human rearing over thousands of years, as Lev Vygotsky told us. And in fact, it is this lack of nurturing care more than some really bad, novel, mutated gene that is resulting in developmental and behavioral abnormalities. And hence, taking away this human scaffolding, the zone of proximal development, as Lev Vygotsky told us, makes children unable to develop all these symptoms or all these normal things. And into this, when the digital world comes in, it actually worsens the human engagement to a further level. It just takes away the human engagement and worsens the digital interaction, worsens the pattern learning. And hence, if the family members were replaced by screens and neighborhood were replaced by this early dash to school, we are seeing all these symptoms coming more and more in children right from early age. And the real cause is what you see on the left, the replacement of family members with screen and the replacement of neighborhoods with too much of structured learning in schools. But what's going to happen next is even worse. From cradle to cloud, because now the child is exposed to unreal things. The developing brain does not even get a strong grounding of what is reality versus what is artificial. And I'm afraid, my dear friends, that in fact the last 25 years have seen a massive increase in ADHD and autism, and the next 25 years is going to see a huge increase in psychosis. So what do we do at New Horizons? Using nurturing care, we actually coach parents to stop object and pattern training and to stop pattern teaching of speech and academics and start with human engagement, develop understanding of human behaviors, the exact way that MKC Nair sir talks about habilitation, not rehabilitation. Habilitation is when you are helping the child achieve the normal milestones because he has missed the earlier milestone. Rehabilitation is the child was absolutely normal, suddenly met with a motor accident and now has a fracture, so can't walk. That is rehabilitation post the plastering, etc. But what Sir tells us is habilitation start at the bottom. What we have only done is provide a milestone or a sequence chart that you can work on. And hence, what we do with these children, whether they come to us at 2 years, 3 years, or at 12 years, or at 15 years, is a shift from symptoms to sequence. We target the sequence-wise interventions depending on what the child has mastered, not targeting the symptoms, but actually the sequence. Parent coaching is far more important than only those therapies because only therapies induce pattern training. Coaching parents to cut away the patterns and to cut away the objects and replace the screens with humans is more effective, which is why human engagement is very important. And that comes exactly what Sir said, habilitation and using the family as an ecosystem rather than just Dr. Dalwai or some therapist. So the key principles of our program in autism is don't get stressed with reports, don't begin with speech, reading, writing, don't validate symptoms like speech delay, so-called calling speech delay as a diagnosis, and don't initiate symptom-based therapy, but focus on human engagement, get the child to engage more with people, less with objects, focus on daily behaviors, and coach parents to be the primary intervention agents. And hence, even if the child comes to you at 4 years or 14 years, do not start with speech and reading and writing. Start at the bottom, get the human engagement to be 100%, then the social behaviors, then the non-verbal. And I promise you that the verbal and reading and writing will improve by themselves. Another very important is that, doctor, my child is not engaging with other children. My child is not speaking. Can I put him in school so that he can engage with other children and develop speech? That's not happening. What we follow at New Horizons is first get the child to be engaging with primary caregivers, then family members, then adult relatives, adult neighbors, adult strangers, and only then older children, and finally peers of the same age group. So we don't target speech and academic because it only leads to meaningless repetition of nursery rhymes like echolilia. What we target is, can the child stay overnight with the kaki, masi, bua, mami, chachi, pui, etc., etc., without the mother? Because then these are different people. There is no one pattern. So the child learns to adapt. And our goals are social engagement, behavior, communication, milestones in a step-by-step manner, again with family, relatives, older adults, older children, and then peers in a step-by-step manner. And step-by-step coaching using this NHDP algorithm has helped us to get children ready for school with the capacity to manage teachers and peers. We see that what are the behaviors that most significantly impact adolescent morbidity: inadequate physical activity, poor nutrition, sexually related behavior, substance use and abuse. These are not independent, but these worsen the already set problems that adolescents have due to autism. And then this worsens it. So we must understand that we have to work on encouragement, the behavioral change to implement regular exercise, healthy diet, avoidance of substances, and very importantly, judicious use of media. Now, if you are able to do this, the larger component of habilitation of neurobehavioral conditions is just getting the parents to understand this in a step-by-step manner. And we've even shown success at achieving this on an online platform. I'll just play this video if it plays for a very important message.
Special children के parents को हम सिखाते सबसे जरूरी चीज है that your child should be able to spend 2 days with Chachi, Masi, Bua, Mami without you in their house, doing what Chachi wants in Chachi's house and doing what Masi wants in Masi's house. For me, a child who is able to do this is a normal child. मासी बोलते रहे ठीक है अच्छा है लेकिन फिर और भेज दे 2 दिन के लिए. She is welcoming him back because he is adjusting to her. He knows मासी को कैसे हैंडल करना है. Masi's house is welcome. This means that this child is normal. Why I'm saying? Because now we can survive without the mother and father. If something happens to the mother and father, eventually will happen. This child can stay with the rest of society, and the rest of society is happy to keep him with them. Then आपको वो इंश्योरेंस हो गया कि मैं नहीं भी हूं तो मेरा बच्चे को सोसाइटी संभाल लेगी. स्पेशल चिल्ड्रन के.
So hence, to close, let's remember the key messages for every parent, whatever is the age of the child, even at 14, 15, autism is not the final sentence. Don't be obsessed with treating the symptoms, because you will only end up teaching the child patterns and to live in a patterned ecosystem. Instead, target the root cause, which was poor human engagement. Keep screens and autoplay objects or all vastus that we call away, which are meaningless for the child. And all family members, beginning with the father, need to be enrolled. The grandfathers, the maternal, paternal grandfathers, kaki, masi. And in India, ladies and gentlemen, dear friends, we can do this. So thank you very much for a very, very patient listening. I have taken exactly 29 minutes. And thank you for being so patient and kind, especially all my seniors who had the patience, who have been teaching me all my life, and who have the patience to hear this from me. Thank you so much. I'm very grateful and always blessed to have your guidance. Thank you.
Samir bhai, it was such a wonderful talk. No words about that. Very, very eye-opening, I would like to say. And has cleared so much every funda regarding not only the ASD, but all kind of an NDD, which is, presenting and adolescence. So that was beyond words. Thank you so much for being with us today.
Thank you so much.
Thank you,
comments?
Samir bhai. Thank you, Samir bhai. Thank you so very much. We'll go away with two words, I think, which shall echo. One is human engagement, and the other is habilitation and habitualization. Right? Thank you so much, Samir bhai. Thank you so much. So,
having a few words from Dr. MKC Nair, sir.
Yes, sir. Professor Nair.
I think it was so wonderful. I was just listening to every word of it. I've heard him before, but now he has crystallized the concepts into one word: human engagement. That probably is the last one. In fact, I'll give an open request to you. I'm just going to publish a book on early intervention. It's called Parent-Mediated Intervention. Okay? So if you can write up this into a small 3 or 4 page, it will be there. But quickly give me if you can.
It's my honor and privilege.
Because it is parent-mediated intervention. The book is on parent-mediated. So the title you can give us, importance of human engagement. The rest, whatever you say is okay. Yes. That word is critical, human engagement. I'm just telling this for a long time, but you gave the right word for that. Thank you, sir. Thank you
so much, sir.
Thank you, sir. Dr. Tuteja sir wants to say something. Sir. सर आप अनम्यूट करें अपने आप को सर.
I listened to him second time. I think about last year I listened to him, and it was recorded, and the podcast is available on the video. Video podcast is available. You can listen to him anytime. With now he has added few more things. Thank you very much.
Sir. Thank you, sir. Thank you.
Thank you very much. Thank you. Blessed.
So going by the clock, and thank you, Dr. Samir Dalwai, once again for sticking to the time and holding our attention so captivatingly. I can promise the audience, we are in for another session, which will be equally captivating for everyone and a lot of learning to come. So please be there and please be tuned as I hand over now to Dr. Chaya Prasad to moderate a symposium wherein she has very eminent panelists in Dr. Sivaraman, Dr. Navina Karthik, Dr. Swati Khate, and Dr. Somshekhar. And they shall be taking us on a journey through case vignettes wherein adolescents with neurodevelopmental disorders, what would be the pediatric practice perspectives? So over to you, Dr. Chaya, for taking us on this journey.
Thank you very much, Dr. Shamik. And at the onset, my pranam to MKC Nair sir, to Teja sir, And thank you so much, Sushma ji. Really, you are at another level, and your ideas and thought process of creating so many excellent programs, academic programs, is really good. And my regards to everybody present over here. And Dr. Samir, my mentor as well, thank you so much for this outstanding talk. And it has actually set the tone for today's panel discussion. And you clearly mentioned that there should be no definitions. We should go beyond the definitions, and we should go deeper into the clinical reasoning and into the systems, and not just keep on treating the symptoms. So carrying forward that now into the real world cases, and where neurodevelopment is really very linear and layered. So going ahead, we start with a panel discussion. And just a few things before I invite our panelists to speak, that as we have just heard from Dr. Samir, that the adolescent age is not just a transition, but it is an age where the adolescent is getting to know his identity. He wants his independence, his autonomy, and he, at the same time, he is also very vulnerable to so many different conditions. So what we get to see in adolescent is not just intellectual disability or ADHD or autism, but we are seeing the layers of the biopsychosocial challenges that we are seeing. So when we look at an adolescent with neurodevelopmental disorders, we have to look at those layers, that there is a biological layer, there's a psychological layer, there's a social layer, and also that we have to understand the adolescent through these layers. And today our panelists are actually going to present these cases where we might see different kind of cases, whether it's a misunderstood adolescent, as Dr. Samir already said, or there's an adolescent who's emotionally struggling, there's an adolescent who is functioning but not yet functioning independently. So I go ahead and invite our first speaker for today, Dr. Sivaraman sir. Dr. Sivaraman sir. Yeah, we are very honored to have you today. And can we have your slides, please? Most welcome to this panel discussion tonight.
Good evening, madam. Are my slides visible, madam?
Yes, sir.
Yes,
Yes,
audible
yes,
also.
welcome. Yes, sir.
Good evening to one and all. First of all, I take this opportunity to thank both the chapters who have invited me. It's a pleasure for me to speak in front of my teachers also, like Dr. MKC sir, Teja sir, Samir sir, and all the office bearers and all the stalwarts of adolescent and developmental pediatrics. So, what was the goal of the purpose of this meeting today was to combine both these things together, because most of the problems which begin from childhood go on to adolescence also. So the first case now will be taking up on a child who is growing up with ADHD. What are the challenges this child has met across the school, home, and the mind? So this is the first case we are going to be talking about. So he is a child by name Naveen, 13 years of old, was diagnosed as ADHD, and his symptoms have escalated for the past 6 months. He has been diagnosed by our team by around the age of 6 months. And the striking thing about the father's history was he has a frequent change in jobs. He's a very authoritarian type of parent, and a lot of familiar conflicts are there. So the presenting complaints now were frequent mood swings. He was not interested in studies, and he was not interested in going to school. Definitely there was school rejection. He had an academic decline with sleep issues. The mother was overwhelmed, resorting to scolding, and this child had low esteem now, thinking that I'm stupid and I will see. So how do we go about from here with this? So before we go on to that, just a little on the neurodevelopmental basis of an adolescent behavior. So we know that the adolescent is the second phase of neuroplasticity, because that is the time where more pruning as well as myelination is occurring during adolescence. So, and it is a dual system model now. I'm talking about a typical adolescent now, where there is a limbic system which is maturing, which is actually maturing little earlier than the prefrontal cortex. And we know the functions of the limbic system or what happens in the limbic systems are more of emotions and reward, and what happens in the prefrontal cortex is more of an executive control, which happens later on, that is mostly after the second decade. So now I have a child, now even a typical child, who has an imbalance between his reward and his control. Like, if I want to explain it simply, I will tell that now I have a child who is becoming an adolescent, and he is having a BMW car, and he has a brakes like that of a Maruti car. So he becomes a powerful accelerator. He has the thing to tell, I want to do it now, I want to do it now. But actually his brains are, should I do it now? So this is the imbalance which is occurring to him. So because of this brain imbalance, we see all these behaviors which are happening to him in a typical adolescent. He has the risk-taking behavior, the emotional liability, poor impulse control, reward sensitivity, and mood variability. So these are all the things which are happening in a typical adolescent. Now let us take what has happened to my child, or what we have managed this child, in a child who has got an ADHD. So ADHD is just not one behavior. We are not just going to tell him based on his one behavior alone. It is a network where different regions of the brain fail to communicate effectively. This is the cause for the inconsistent performance which happened in the case of Naveen. So let us take this again as an example. There are three things which control in an adolescent brain: the executive control network, the default mode network, and the salience network. The executive control network is called the CEO of the brain, and the salience network is going to be the manager, and the default network is going to be the employee. So what is happening now here, when this executive control network goes off, he has weak control over himself, he becomes very impulsive. If I have a CEO who is very impulsive, definitely his manager, salience network is not going to work. He's going to have poor filtering, and the manager is going to think everything he does, he feels it is very important. And what happens to the employee? He goes into the default mode network, which is controlled by the medial prefrontal cortex. So this medial prefrontal cortex fails to switch off. This is the cause for most of the children who have inattention. And to add to all this, there is low dopamine and norepinephrine, which are the network which causes the network insufficiency. Now moving on to the two most important things which happened to this boy Naveen. He had mostly emotional outbursts and impulsivity. So Naveen used to always react impulsively, get into fight, and regrets it afterwards. So here his ECN was very weak, and he went into emotional dysregulation. His amygdala always kept firing. So usually we know that there is a fight, flight, and freeze mode. And now only his fight mode is being activated. So he keeps on, reactions keep happening before the reflection, and then he has to regret, and shame follows. This led on to the rejection cycle, where impulsivity reactions in social situations had happened. He gets angry, sadness and shame, further emotional dysregulation, and he becomes more impulsive. So this rejection cycle keeps on continuing. And if we do not interfere with this before this rejection cycle, if our interventions do not start early, then he may end up with a lot of the complications with an ADHD child.
Dr. Sivaraman, I'm sorry to interrupt you. There's a lot of background sound. Is there any way, will you like to
Surely,
try?
sir. I'm just off the fan, sir. Yes, sir.
Yeah.
Is it all right now, sir?
Yeah, it's better now.
If you can increase the volume also of your...
It is in the maximum, madam.
Okay, it's better now. It's
but
better
it
now.
still is better.
It's better. Okay. Now we have the second thing is the hyper-focus paradox, which has happened to this child. So Naveen becomes deeply focused for hours while doing art, and he was very much interested in shuttle, which was his favorite activity. What is this hyper-focus paradox? So most of the parents, when we see children with ADHD, the parents always will tell, sir, he can focus when he wants to do it, sir. He wants to do it when he wants the activity. Some activities he will do, but sometimes he will not do. This is actually a common but incorrect conclusion by parents. So we should know what is an hyperfocus paradox. Here it is, this child shows a high interest and passion for certain things which he wants to do. So his dopamine levels become more, his brain networks synchronize better, and now his ECN gets activated and his DMN quietens. So this leads to excellent focus. So what is happening here is hyperfocus is the brain chemistry plus the network activation. It is not his willpower, because most of the parents whom we meet will tell, sir, his willpower to do, sir. Sometimes he can do it, he doesn't want to do it. So his interests tasks are provided with the dopamine boost which is happening in these ADHD brains. So this is not a choice for him. We should understand this is neuroscience in ADHD. So what are the contributing factors for Naveen? So the contributing factors for Naveen here is we look into it as a biopsychosocial model. So we have talked about all the the biological on the neurodevelopmental core, his ADHD related executive functions. He definitely had poor impulse and emotional control with weak sustained attention. Now let us talk on the emotional and mental health layer. Yes, this was the child who was getting emerging anxiety. We had anticipated this. And he did not, unfortunately, have depressive symptoms, but he started getting rejection sensitivity dysphoria. This is the emotional pain to criticism which this child was undergoing. Because of this, he was getting peer rejection in the school. His impulsivity was increasing in the social context, and again, rejection, anger, and more dysregulation. This is in the social context. And in the academic front, his transitional age 13 demands were more. He had to study more. He had repeated failures, and he developed learned helplessness. So this is the problem with most of the children with ADHD we see. There is a cognitive versus a performance mismatch in them. Imagine I'm sitting in a class with ADHD. I know I can do 100%. My IQ is good. I can do 100%. But when it comes to performing, I cannot do it. Imagine the plight of this child. And as pediatricians, I think this is where we should take the opportunity to help these children. What has happened to him in his family? There is definitely caregiver burn down, guilt frustration cycle, and low positive enrichment and reinforcement was taken on. And to add to all this, he had sleep dysregulation, excessive screen time in the night. So this is the model. We look into it as a pediatrician. We have to go through the biopsychosocial model. Let's look into his family dynamics. What has happened to him in his house? So this is the common thing which happens. There is a misunderstanding. The misunderstanding is first within the parents, then within the relatives. So usually this child with ADHD is always told, this fellow is a rude fellow. He's a future psychopath. He's a careless child. He wants to do careless mistakes. So this is the common misunderstanding. We as a pediatrician should try to break it. Then the next is the judgment. What is the judgment which is happening? Not by the parents alone. It is by the society, his relatives. Parents face the blame that this child's behavior, they are not able to take him out for a gathering. This increases the stress. And what does the parent get? Bad parenting. This is what the name the parent gets. And this fans the flames to the, this adds to the flame to the parent. And now the third thing which happens is the shame. Shame for the parent as well as the child. So shame is a core emotional experience for individuals with ADHD. So if he gets into shame, he's going to go into rejection. We are going to fail in managing this child. And the next thing which is going to happen is the guilt. Parents may feel guilty that they blame themselves for what has happened. They are not able to control their child. So these are the social issues we should try to address when managing children with ADHD. And the next thing which happens is the behavioral dysregulation and the meltdowns during family settings. So what was the need for this strategy now? So this was what was the working diagnosis. He was diagnosed to have ADHD, predominantly hyperactive with impulsivity. He had definitive scholastic performance, which was low. He developed learning disability, learning difficulty, not disability, learning difficulty with the comorbid ODD plus sleep issues. So this was what was our working diagnosis. Now, how did we proceed with them? Some red flags which he didn't have, which I would like to highlight for all the pediatricians, is having negative self-talk. I am stupid. So this leads, you have to take it as a red flag. Depression, school refusal, more than 2 weeks, and social isolation. These are some of the highlights we would like to highlight to a pediatrician. So what was the framework we formed? Definitely we did a good clinical history. We tracked back on the school reports and teacher feedback. We did a Vanderbilt, CBCL, SCAD, and strength and difficulty questionnaire given to him. Cognitive testing was done. We did the brief 2 and behavioral observation at school. Medical evaluation was done with the thyroid functioning testing and hearing and staining vision. We did not do any sleep study. Now, what was the intervention planned for him? With the help of a pediatric psychiatrist in our team, we did a cognitive restructuring for him. Wherein he went into his thoughts, we tried to remove what were his negative thoughts. We want to give a feedback to him how he could get out over these thoughts. We call this as a cognitive restructuring, which was done with the help of a pediatric psychiatrist. We had a behavioral activation strategies, emotional regulation was done to him, and mindfulness. We are taught about mindfulness to him. And most important, as a pediatrician, we should look into sports and nutrition for these children. He was started on methylphenidate and he was doing well. Around 1 year he is on methylphenidate. We did not put him on atomoxetine. He is somehow doing fairly well with methylphenidate, and we continued with the methylphenidate. He was put on melatonin for his sleep problems. He's doing very well now. So just what is the key insight here is it was just not an ADHD anymore. It becomes a complex ADHD with learning difficulty, ODD with the emotional dysregulation, with internal disorder profile requiring it was a multimodal plan which was done for it. So what did we do for him now? In the school, we make it as a habit to talk with the school teacher, especially when we ask for the Vanderbilt, filling the Vanderbilt form, we talk with the school teacher. And after we have done the assessment, I think it is a duty for all of us. If you are too busy enough, you can ask even your friend desk to talk with the school teacher. That gives you a lot of information, because most of the times when we do a Vanderbilt screening or any screening, there may be some discrepancies in the scoring. So it is always better to take the help of the school teacher to find out what he is at school. So we had talked with them, and these are some of the classroom modifications we had given to him. Preferential seating was done, reduced classroom size. We also advised movement breaks and extended time for the exams. Task management for him, we are definitely advised on task chunking, that is breaking down tasks into simpler steps. Visual checklists were given, daily planners with the teacher sign off, and one instruction at a time approach. The positive behavior support given to him was by the parents. So catch him being good, because most of the time these parents, they don't try to encourage him. Anything he does, which in a small manner, try to encourage him. He was given a DRC, that is a daily report card with token economy, and parents were not taught to publicly remand him. With this brings down his self-esteem. Academic support was given in the form of remedial educations, IEPs, peer tutoring, and reduced performance pressures. So after this, what was the second thing which was done? This was for the child, and we focused more on the parent empowering. Now this parent we have made him to shift from reactive scolding to unpredictable discipline plus criticism to guilt to a predictable, structured, praise-based and positive reinforcement parenting. We always told him, why is Naveen not listening? We are taught the parent. Instead of looking into that, can you just think and say, how can we make it easy? This was what was taught to most of the time to the parents. The parents were counseled, they were psychoeducated. The father, in fact, has changed a lot from an authoritarian parent. He has become very authoritative now. And he is fixed to one job for the past 8 months. He's in one job. He somehow changed the pattern of living for him, which has helped a great deal to these children. So what were the key strategies we followed was 10 to 15 minutes of uninterrupted daily
Dr.
special.
Sivaraman, sir, sorry to bother you. You have two
Just
more
2
minutes.
Yes,
You
madam.
have
Yes,
2 more
madam.
minutes.
Last 2 slides. One-step instructions were given, token economy was given, and the parents were made to feel comfortable, and this was done with for most of their time for these children. So most of the time we look into the challenges, but we emphasized on looking into his strength. He was good in painting, he was a good drawer, he was good in shuttle. So most of these children with ADHD are highly passionate and enthusiastic. They have hyper focus on interests. So I think we should try to encourage this. So outcome of the goals is reduced emotional outbursts have come down by almost 50% in the past 1 year. He is able to complete his tasks at home. At least one stable, he has got at least now 1 or 2 friends with him. He is able to bring friends to his house. The family is functioning better now. There is no parental stress. There is a positive parenting. He sleeps well. And this is how we are able to do what good we have done for him. These were some of the red flags we would like to indicate: suicidal ideation, school refusal, substance abuse and severe depression, internet gaming addiction, and psychotic features. Please, these are red flags which needs immediate referral. And we have a list of carryaways, but being practicing developmental pediatrics for over the years, we have been seeing a lot of children with grade 3 or 3-4 GMFCS. We see a lot of low functioning autistic children. In ADHD, what I always feel is this is one of the problems I would like to manage, because we see them giving good results. You just need to intervene early. You have a biopsychosocial approach and you can do wonders for these children. Yes, we know ADHD is a complex multi-system challenge, but just don't treat the impulsivity and the inattention. There is co-occurring learning difficulty and anxiety, which has to be actively screened. Reduce the screen time. You need a multimodal of management, and most important is the caregiver empowerment is central. The problem is not in this child's brain. It is only that his brain is not able to perform. You should understand the plight of this child, where he knows he can do everything, but he's not able to do. This can reduce the stigma and increased understanding. So ADHD comes with genuine strengths. I think as a pediatrician, we should try to increase all these strengths. Thank you, madam. I think I finished on time. Thanks again, madam, to
Thank
all
you.
of this
Thank you so
opportunity.
much. So that was Dr. Seva Raman sir, a senior neurodevelopmental pediatrician from Erode, and excellent talk, sir. And you
Thank you.
beautifully explained a very complex case of ADHD, and you very nicely enumerated what is the importance of executive functions and the emotional regulation, as well as the involvement of the family and all of the complexities that are involved in this case, and very nicely taken care of. And the management plan was very well designed for this child. As we say that every adolescent, every child requires an individualized plan. So very well done in that. So any comments, or should I go on to the next case?
We'll take the comments at the end.
Comment. Yeah,
I would just like to say it was an excellent talk.
Thank you, sir. Thank you, sir.
An entirely different style of talking from the usual, stuff we talk with that. And particularly, this is
Thank you.
important when you are dealing with adolescent ADHD. You can't treat them like small children, do this, give a list of items to be done at home. No, you can't. It has to be a dynamic management. Depending on the need of the child. I think you have excellently put it across. Thank you, sir.
Thank you, sir. Thank you, sir.
Thank you, sir.
Thank you. Thank you so much, sir. And moving ahead, now I invite Dr. Swati Ghate, and again a senior developmental pediatrician from Jaipur, who is now the joint director at the Babylon's Newton Institute of Child and Adolescent Development. So, Dr. Swati, can we please have your slides and listen to your interesting case as well?
Thank you so much. Am I audible? Am I audible?
Yes, yes, you are.
Or are my slides visible?
Yes, they are.
So many thanks to all the members, senior members who have given me this chance, and my respectful regards to MKC sir and to Teja sir and all the other seniors. So after this wonderful talk by Dr. Sivaraman sir, let us see another case. He is Shubham. He was referred to our center by his school. He is 15 years and 10 months old, studying in 11th standard commerce stream, and was brought by his mother because he was expelled from the school and for 15 days, and the school wanted an evaluation and report before he is reinstated. The main complaints that the school had was a long-standing academic underachievement and indiscipline, which was rising day by day. And in the recent past, he had shown some indecent behavior. That was the word they used when we talked with the parents and the teachers. So coming to the details, he was always a child who was not interested in academics, always having his pending assignments and all, below average in studies, and he failed in 11th standard. He was made to appear for the retest, and while appearing for the test, he went off to the school toilet and rang his mom and wanted her to tell the answers which she would tell from his book, because the mother was only taking his looking after his studies. And while he was doing so, he was caught by his teacher. As expected, many things happened. He was beaten up by his father, and mother wanted to protect the child. The school teachers were very angry and rusticated him. On the same day, he shared an objectionable video to a girl classmate. This girl again reported it to the next day in the school, and they then just the school wanted him to be out. As such, he was not a very bad student on all the aspects of schooling. He was given the responsibility to head a house, a cultural house in the school. He was into some music and band, and also he was good in badminton. So at home, mother told that he is very caring and emotionally reciprocative. He is generally cooperative and shares her household responsibilities, but he was stubborn in some issues. Like there were always conflicts with him regarding driving the car and also wanting to join a gym, which his parents were not ready. He was obviously not very interested in study, and that was also a point of great conflict, and it had all risen post-COVID. He was never sharing school experiences and didn't want to open up when he was like asked how he behave, how is his experience with the friends, what he does outside school, but he was always mute on that. There were occasional anger outbursts, and parents have noticed that there is a lot of sibling rivalry. He was lying at times, but there were no destructive behaviors or stealing or any other behaviors of that sort. Perinatally and developmentally, he was normal in the first few years. But in the primary class, the school would always report that he is a naughty child and he indulges into frequent fights. When I took him for the head assess, some points that I got was his younger brother was academically good, and that was making him really worry about himself. His father was an authoritarian man, and mother was always hovering around him, and she was overprotective in his from his perspective. She would not let him go anywhere. She would not let him stay alone at house, and she would always see what he is doing. He did enjoy sports and theater as well, but his social media interactions were limited to YouTube, and he did not have many social media friends as well. He was like never taken in the group by the classmates, and they would always say that tumhe nahi samjhega, ye hamari cheezein hai, and he was very sad for that. He was not indulging in any drugs, and there was no sexuality concerns. Mood was generally good, and also that was the same as described by his mother. He was feeling safe at home, but was afraid of teachers, and this was the important points on head assess. So general examination was well within normal limits, and with vision and hearing clinically normal. He had entered puberty as well. When I was talking with him, mental status examination revealed that he has a very good eye contact and was easy to connect. But surprisingly, there was a smiling face, and there was no remorse of what has happened 2 days back that he was expelled from the school. There were no apprehensions also. He was oriented, but while talking, he appeared distracted. Many times he used to talk something which was about telling me something which was not relevant. He was fidgety and was playing all the while with his wristband. He was over talkative, but his thought contents were little age inappropriate. When I asked him what made you behave like that, he had many like reasons which were not developmentally appropriate, and they lacked the adolescent flavor. So he said that I want to build muscle so that my classmates are afraid of me. So that video is not a big deal. We share many such videos. That video was obviously had some sexual contents. I was scared of failing and staying back in the same class, so I called mom for answers. So he was very plain and blatant, and he was like, it appeared that he is not mature enough to answer such questions. So my clinical impression was they had poor school performance with behavioral problems, maybe conduct disorder, and I had a feeling that he could be a borderline case. So a normal evaluation for TSH, CBC, and other things was normal. His Vanderbilt test was given to his parents and teachers, and SCARED form was also given to his parents. And I planned for IQ assessment and LD test SOS. So the results were available. I talked with the school also, and it was predominantly inattentive type of ADHD, though there were some traits of impulsivity as well. There was no evidence of any conduct disorder on Vanderbilt, and SCARED also showed no anxiety issues. The IQ test and elaborate test was not possible because he was like very sort of a fidgety and inattentive boy. So, and the school was like pressing hard. So we just thought of getting a quick IQ assessment, which we did on Raven's standard progressive matrices. It is a test that it is a test for general intelligence and abstract reasoning, where visual patterns are shown with missing bricks, and there are 6 choices given to the child, and he has to choose one. And as the test advances, more and more complexity is given through these visual challenges, and then the scoring is done in a particular way. There are 5 sets, and each will have 12 cards. So when done on this Ravens, his score was 37. It was below 50th centile and called as grade 3 minus, but then this was falling within the average range of intelligence for this, according to this Ravens. So we did some psychoeducation of parents and teachers. Sir has elaborated on all the things that we should do for an ADHD child. Methylphenidate was started. Child was counseled regarding media literacy, anger management, underage driving, and bullying. We required 2-3 sessions to deal with all these things, just touching upon them and making him realize that these things need to be addressed in a mature way. And parental counseling was also done to give him some autonomy because he was really struggling for that. Activities to increase span of attention were advised in the form of some board games like carom or some other basketball or many other things could be advised. We advise these 2 things. Activities to raise self-esteem were also advised to the parents, and he was given a chance to indulge into hobbies, which was like some instrument he used to play. Career counseling and remedial education with individualized education plan was in our management. So after giving methylphenidate for 1 month, we did his music, and his IQ turned out to be 81 with verbal component with 84 and performance on 78. His social quotient was 85. So we did the final diagnosis of borderline intellectual functioning with ADHD. So coming to borderline intellectual functioning, why I wanted to present this case, because this thing is very, very pretty much common than we probably assume. 12 to 14% of the population which are falling 1 standard deviation below the normal IQ mark of 85 will fall into this, and by our normalcy curve, the population should be 13.6%. So these children have limited cognitive and adaptive functioning, lesser than the normal, but better than those who get the official diagnosis of intellectual disability. The IQ scores range between 70 and 85, and 27% of people with borderline intellectual functioning are supposed to never get diagnosed, and they carry on their life. They generally present to us with poor school performance and behavioral problems, both internalizing and externalizing. They are very much educable and can lead fulfilling productive life if they are supported timely and systematically. So because they do not have a formal diagnosis in the diagnostic manuals, there is like DSM-5 and ICD, there are no legal, academic or social support, and they are a blind spot. They are placed and listed into additional conditions that may be a focus of clinical attention. Generally, they are seen to show very many heterogeneous profiles, and no uniformity is seen in their low ability. So they might be low in executive skills, memory, abstract reasoning, even the language. They might be good in something other like sports or maybe some form of art. Importantly, they have an insight that they are little different, but they try to mask it and behave normally. Psychopathologies seen with borderline intellectual functioning are as high as 40%. The challenges they face are on many domains. They are not good at interpreting social cues. They cannot probably empathize and cannot carry on friendships. They are like bhola bolte hai unko sab log, and they are always vulnerable for bullying, social isolation, exploitation of various sorts. Independent personal care, health care, transportation, all are a big challenge to them, and they always need some support, at least in the initial years when they are still not completely functioning as adults. They are also victims of crime and also perpetrators because they don't know cognitively what they are doing. So they always land in some trouble or the other. School dropouts are common, poor skill building is there, underemployment, and mental health problems as adults are very, very commonly seen. So how we can help? Obviously, early intervention is the key. We all know the neuroplasticity, and we can definitely mitigate cognitive deficits by properly holding their hands. Structured environments are better, where they have some predictability and they have simple instructions, and chunks of small tasks are required to be done. Tailored services for adaptive and life skill training are very, very important. Individualized education plan and vocational support is all that is very necessary for a productive adult life, and screening and addressing comorbidities is very essential. So what pediatricians can do? Pediatricians have definitely to support for the perinatal and nutritional health, as we all know. Neonatal screening is of utmost importance, especially the thyroid and the hearing. Then as pediatricians, we have to promote nurturing and stimulating environment. Samir sir was talking about our NCCD plan. Watching for cognitive abilities should be made a part of our general examination when we deal with any child who is coming for any reason to our OPDs. We should not just stop at sardi, khasi, jukam, but also now we are always telling that we have to look after the psychological aspects also, and this cognitive aspect is also equally important. We could interact with the child and guess what is his intellectual capacity. We can ask parents if there are any concerns regarding his development, because what happens after 5 years, we generally we don't indulge so much into the development. We only focus on weight, height, and all those things, but we do not ask pertinent questions about development once the child is into the second half of the first decade and also into the adolescence. So we could give them
Dr. Swati, we have 2 more minutes. Thank you so much. Yes.
I'm coming to the end. So we have to do we can give them some simple academic tasks like writing the name or writing some simple words or giving them something to read. There are also some office-friendly quick tests, like this is the Gazel's drawing test, which can definitely tell us like where the child stands on his cognition. This is a draw man test, and adaptive skills can be taken up by asking some questions for this very popular Vinland social maturity scales. This starts from 1 to 16, 15 years, but after 5 to 6 years, we could make it a point to ask a few questions. Like, can he be trusted with money? Does he go to bed unassisted? Does he understand that family secrets have to be kept within the family? Can he make minor purchases? Can he distinguish between friends and playmates? Such type of simple questions will also give us an idea as to his cognitive development. So definitely whenever there is a problem, we have to go for formal assessment, then caretakers empowerment, and educating them about this problem is very, very essential. Skill building, we have talked about. Emotional health, also the physical health. If one of your patients is borderline and he is having, say, asthma or diabetes, then he is going to be a great challenge for you to handle him, and the compliance would be much lesser than a normally functioning child. Educational support and career guidance. This is this picture showing theory of multiple intelligence by Howard Gardner. Sir was also telling just now that we have to look into some different areas of interest where the child can progress and live a productive life. So the take-home messages are: borderline intellectual functioning has significant prevalence, but it's easily missed. It presents as internalizing or externalizing problems. Substance abuse is also very common in these children, and parents are generally, they have an idea that something is amiss, but they will not come forth and open up. They will just want to hide it under the carpet. So quick cognitive assessment in pediatric OPD is possible and should be done. Partnering with parents and teachers is very essential. Promoting self-esteem and working on strength is the key. Detailed psychometric assessment and testing by psychologists is very essential, and psychosocial intervention and support is something that a pediatrician can offer through a team approach. Thank you very much. These are my references.
Thank you very much, Dr. Swati. Excellent case that you presented. And as we can see, this was another case of adolescent with ADHD, a complex case again, and where we needed to deal with this case in a different manner. So thank you very much. And due to shortage of time, I think we are just going to run to the next case, because we want our all our viewers to stay on and listen to all the cases before we take up questions. So I am going to invite Dr. Navina. And Dr. Navina Karthik is also a developmental pediatrician at the Kaveri Hospital. So Dr. Navina, can we please have your slides?
Yes, ma'am. Thank you. Good evening, everyone. Thank you for the opportunity. Is my screen visible? Can you see the slides?
Yes, we can see it.
Yes.
Yes.
Yes. So, good evening, one and all. My topic for today is about life skills for adolescent with intellectual disability. So, moving on to the case scenario, this is a Vedant, a 14-year-old boy diagnosed with intellectual disability. He is studying in grade 8 in a mainstream school with a resource room support. The strength, like he is a visual learner, he likes computer drawing, he has a strong interest in animals, follows routines well, he has a limited peer interaction. At a glance, everything seems to be going well. But is he really doing well? Are we looking at the right outcomes? So when we let's take a closer look across the settings. Like at home, if we see, Vedant needs prompting for his regular daily activities, including his bathing, grooming, needs help for his dressing. His mother largely helps him with his routines and organization, and he's fully dependent for school preparation. So we could see that he participate, but the independence at home is quite limited. And when we see at school, he attends school regularly, but he completes tasks with support. There is challenges with the attention, task initiation, and completion. Structured environment help him to perform better. So with structure, he functions well. And moving on to the social world, he does not initiate engagement, does not initiate peer interaction. He avoids or dislike group activities and has very limited social interaction and limited friends. Social participation is quite restricted. And when it comes to community level, the challenges becomes very evident. Even simple tasks like going to a shop, buying something from a nearby shop could trigger anxiety. And he has difficulty with the money concept and making transaction with it. And he depends on his caregivers for problem solving and decision making. So real world exposure is quite challenging. So when we look at the psychometric assessment, it was done by the age of 10 years. His cognitive functioning, according to the WISC, it falls within the mild intellectual disability with the IQ of 65. And with the adaptive behavior scale, he significantly has a low adaptive functioning. And the similar way, he has a delayed social maturity. So what we could see is the There is a mismatch between the cognition and the adaptive functioning, and this clear gap between the performance and the functional independence. So this gap is mainly due to the deficit in the life skills, which is shown in this delay in the functional independence in the real world. So when we talk about the life skills, so let's see what are the life skills. So according to WHO, the definition goes like the ability for adaptive and positive behavior that enable individual to deal effectively with the demands and challenges of everyday life. To put it simple, these are the ability to maintain a state of mental and physical well-being where one can interact with others within the local culture and the environmental expectations. So when we talk about the life skills, it includes daily functioning skills, their health and safety skills, peer relationship, socialization and communication, community participation, which are the instrumental daily living skills, transportation, leisure, recreation skills, home living skills, career paths, and employment. So the life skills involves the overall functioning and the independence. So there is a difference between the life skills and the adaptive skills. Adaptive skills are part of the life skills. So, for example, we can see with example, adaptive skills are pertaining to the practical skills, their conceptual learning, and the social interaction. For example, if a child or a teen could count money, it is an ability. So, counting money, and when they are able to manage money in the real life situation, it becomes a life skill. And the same way, if a child could pack bag, his school bag, it is an ability to pack the bags. If the same child could pack the bag according to the timetable, using the right books, homework materials without the help of the parents, it becomes a life skill. So this is a slight demarcation between the adaptive skills, but the adaptive skills are part or the subset of the broader life skills. So when we see how we can help Vedant build his life skills, so the major domains include self-care, where Vedant needs prompt. And so this, how can we train is like using the task analysis and routines, which I'll be describing later, so that he can attain independent hygiene. And when it comes to the daily living things, he's fully dependent on primary caregivers. So we have to start with the stepwise training. And with the social interaction, there is not much of initiation from his side. There is not much of friendship. So we have to include the social script, encourage participation in the real life, use of buddy system. And also in the community, he avoids exposure. We have to start with graded exposure to the real world, and so that he can build confidence in the real life experience. And there is also like the functioning difficulty involving the executive functioning, where he has poor planning, poor organization, having difficulty with the time management, where the visual cues, visual checklists, visual schedules could help him complete the task. So how do we do? We always start small, one routine, one real life task. And it is the method we follow is teach them, repeated practice, and gradually fade the support and give the time delay. So consistency build independence over a period of time. So the strategies like task analysis, for example, they can sequence the activity and use the task analysis, or they could also use the forward chaining, where they can train the first skill and then later they can move on to the next step, or the backward chaining, where they can start with the last step and go backwards and get trained. So the prompt level will also be like from fully physical, where they are dependent on their caregiver. They move to the partial physical, where a light touch or controlling the body with a elbow as a guide, or using the gesture like pointing, or using verbal input. Then they can move on to the independent level. And also using the stories, social script for socialization will help him build the social skills and social interaction. So using this planning, sequencing issues, and depending on the prompts. We can use the visual schedules, checklist, and stepwise routines. So according to the ICF framework and the F words, we could see how the deficit in life skills affects his regular life independence. So when it comes to the function, children with intellectual disability have difficulty with their cognition and their adaptive functioning. So they have difficulty with their planning daily tasks, poor time awareness, and they need step-by-step guidance for sequencing activities. So the visual schedule checklist will help them build the routines. And when it comes to the family, there is high parental support. And in this case, mother organize most of his daily routines. So there is an over dependence on the caregiver. So parent coaching, graded withdrawal of prompts, and shared responsibility will definitely help the mother. And when it comes to friends, he avoids group interaction, limited friends. Structured peer play and social scripts will help him. So he enjoys computers. He's interested in animals. So we have to use his interest for engagement and reinforcement, use of reinforcement learning. And when it comes to the future, we have to look about his community functioning. So early vocational exposure training and community-based skill training will definitely help him with this transition to the adulthood. So how do we go about? We have to start early vocational exposure by age of 14 years, where we work on the attainment of activities of daily living, including the instrumental ADL and pre-vocational training and usage of flexible pathways of studies like NIOS, vocational stream options, and using as interest-based pathway. And there are a lot of animal related direction where we can guide the person, roles like pet care assistant, animal shelter support works, structured farm task, etc. So how do we see our role? As a parents, it is important that they gradually reduce the support given and promote the independence. And in school, we have to see that we incorporate the life skills in our regular curriculum. And as pediatrician clinicians, we have to structure and monitor and follow the progress. And with the community, we have to provide graded real life exposure. And parents can have the typical life skill development as a reference so that they can train their children to reach and gain their ADL and IADL in their own pace and potential. So there are a lot of AI which is helping in getting the life skills like virtual reality apps, voice assistant. We have our visual schedule apps to make the daily routines easy, and smartphone reminders for independent support, and for also for wearables where we can use that for our routine tracking, maps, and safety. So we have to talk about the caregiver burden. So we could see that there's a constant supervision, and which leads to time burden, high time spent on the daily task, and this leads to stress, frustration, and long-time caregiver fatigue and burnout. And so there is an over-dependent cycle. The child relies fully on the caregiver. So building independence reduces the caregiver fatigue, and regular breaks reduce chronic stress from continuous caregiving, and even breaks for a short break time or going to a relative's house could definitely help reduce the caregiver fatigue. And it also, the use of respite care services enhance quality of caregiving, allows time for me time, self-care, and health needs, and it prevents caregiver burnout and promotes sustainable long-term care. So life skills are about independence and not perfection, and functional independence is not automatic. It grows with intentional practice. Thank you. Thank you. And these are my references.
Thank you. Thank you so much, Dr. Navina. That was really very comprehensive. And I'm glad that you brought about and mentioned about the international classification of functioning disability and health, and also about the F words, because these are really important for pediatricians and all professionals to know when they're working. So it was a very nice presentation on adolescent with intellectual disability, bringing out all aspects. Thank you very much.
Thank you, ma'am.
Sushma ji, should we go ahead with our last
Yes.
presentation today?
Right.
Or any comments?
No, actually, we will complete every talk, and then if time permits, we can have some comments from sir.
Yes, we are looking forward to comments from sir as well.
Uh,
So I invite now Dr. Somshekhar. Dr. Somshekhar, sir, are you there? And it's a very excellent talk now. Everybody's been looking forward to it. And this is about comprehensive sexuality education in adolescents with neurodevelopmental disorders. So I invite Dr. Somshekhar.
One. So it's time up, and respected MKC sir, Sushma madam, chair, and all the past, present, future presidents of AHA. And this is a very important type of which we recently underwent some training. Since time short, I straight away go to the case and presentation. It's very unique scientific programs are going on. Thanks for that. And let me not go to the what is meant by sexuality and other things. And it is like, multifaceted educational approach is required to deal with a common case. When it comes to the, challenge case, it's much more designed, and more it should be evidence based and should be futuristic with scientific approach. So many myths are there, like, common myths about CSE, early sex, it depresses the children from their innocence. So many abstinence is the solution, and leads to promiscuity, experimentation, irresponsible sexual, everything is there. But what happens when it comes to the children with disabilities? Much more. So let us take with a case scenario. 14-year-old girl is brought to by her mother with a concern about the behavioral changes, inappropriate social behavior, and difficulty in handling bodily images. This is the question. The 14-year-old girl has come. So little delays there, global developmental delays, moderate intellectual disabilities there, around 40 to 50. No details we have got. And functions at approximately around 7 to 8 years of developmental age. So as I mentioned about moderate intellectual disability, presenting complaint is sensory loss is there. She's hypersensitive to sound, intolerance to certain clothing texture, avoids crowded environments, and distress with the physical touch at times. So psychosocial concerns are many increased curiosity about body parts, repeated touching of genital area, act of masturbation, difficulty in understanding privacy and social boundaries, attempts to undress in appropriate settings, poor awareness of menstrual hygiene and bodily changes, vulnerability to inappropriate touch by others due to poor judgment. So these are all the concern with a child with moderate intellectual disability. We don't know what are the history related to the details. This case is taken from a orphanage as such. So menstrual history attained around 12 years, irregular, poor menstrual hygiene. Because in this school, some 30 girls similar to this, it is working in a corporate setup in such a way that somebody can sponsor, a free service is also there, as well as some children are paid and they take care of it. It's a win-win situation. And irritability and anxiety is also associated. Family means, it's, I just mentioned, it is not family, it is that the caregivers are there, difficulty in managing behavior at home and school, the same school, it's a residential school with a hostel, and lack of knowledge how to provide, because the caregivers, their knowledge is around 10th, they're taking care of only the food and the nutrition and the hygiene maintenance, that's all. So if you take the general examination, no focal deficit, no dysmorphic feature, otherwise poor attention, limited eye contact, and repeated behaviors are there, and she doesn't follow the instruction. TANS, of course, breast stage 3, PBKs are there. And this by our president has examined. Home lives in the parents, that's what we mentioned, it's not parent. Education, the special school around, she just do the whatever the limited activities and other things are not there. Only thing is poor understanding about the bodily images. Points concerns are there, many concerns is there. It's with the disability, with sensory processing issues and inappropriate sexual behavior, how to go about this. As such, we also doesn't know about it. So this comes under about types of disability with children with adolescent. Here the question is the chronic medical condition is affecting and with multiple disabilities, one or more. Coming to the sexuality education for the person with disability, especially intellectual disability is often ignored or overlooked, and prejudices are there that intellectual disability either they are asexual in common words in the stories or oversexual and should have their sexuality and fertility controlled due to so many limitations. So many words and discussions are going on. According to the Solos and McAfee, they are very good studies. 50% of males with females with intellectual disability will have sexually assaulted in their lifetime, and the males with intellectual disability are more liable for to be sexually abused. Women with ID are significantly more likely to experience rape, unplanned pregnancy, reproductive right violations, sexual abuse, mental health related issues with abuse, lot of abuse. So as I mentioned about already about thinking that people with disability are innocent, that itself makes them vulnerable, asexual, and the word is there that disability don't need comprehensive sex education. This is the crux of the stories today. Today, what the forum has started, very unique program, is to talk on that they need a comprehensive sex education in whatever they way. That's how we should plan. People with the disability have more important things worry about this than sex. People with disability should only marry and have sexual relations with other people with disability. So many things I started, getting all this information. People with disabilities should not have children. So the Article 23 recognizes the importance of sexuality education to fulfilling sexual and reproductive rights. Nothing that rights of the person with disability to have the access to a appropriate information should be there. Reproductive and family planning educations are recognized and the means are necessary to enable them to exercise their rights and should be provided. This is the United Nations for Convention of the Rights of Person with Disability in Article 23. With understanding this article, so need to be CSE in ID is important, because they are high risk of exploitation, limited sexuality knowledge, and dependency of the caregivers cannot monitor all the time. Needs to their way of education is important, and parents and teacher often unsure how to manage these issues. So lesson to be taught is use the correct names for the top body. For what we can do at our level, when we go as a pediatrician to this center, we do attend from our forum, one of the NGO, we go and attend these children. But I not address these things. Now after learning through this, I start working on this. Use corrected names for the body parts. Give simple, honest, age-appropriate answer. Work with teachers and professionals as a team. Reinforce learning at home. Use everybody's situation as a teachable moment. Be positive role model. Respect appropriate behavior can be taught to them. Self-care and pivotal changes should be addressed. Educate them so that they lots of short targeted training programs are there with the appropriate language and boundaries and signs of sexual abuse to be taught and encourage decision making and independence and respect your child's sexuality and support healthy development. So when it comes to the topics to be addressed is gender identification, naming of the private body parts changes what happens in the puberty already mentioned. Important is about the masturbation, menstrual hygiene, relationship and healthy boundaries, and what are the family members and caregivers can do. And we should demarcate and tell them about what is public and private places. That should be there. And we should teach them what is good touch and bad touch in their own way, and what is danger, saying no to the what is inappropriate behavior. And also we should do a lot of studies related to their marriage, fertilization, contribution, and important is we should aware the caregivers or the parents or the school authorities should know about POXO Act. So what is the benefits overall? It gives a positive self-image for them. They'll understand the body images, teach them already about puberty related changes. Appropriate sexual behavior should be, it should be a part of their program, whatever the training program they'll also. And what that happens finally, they'll be safe and they'll be reduced risk of abuse, exploitation, and unwanted pregnancy and sexually transmitted infection. The main focus of sexuality education is all this, whatever I mentioned. And finally, it improves the communication with parents on relationship and the responsibilities. So rights is important. Mainly about other things is it avoids the exploitation and the assault. We do. It is not only the mild moderate. Finally, even the murder, the assaults, everything is there. So these things of training programs are important. Models of from our forum is important, and they have right to express their sexual feelings appropriately without fear of punishment, and right to receive the sex education regardless of the age, gender, and mental capacity. So let us work out that what is that right to express affections is there, and their right to be free to be sexist or the stereotypical liability is there, and right to make mistake and receive the help is important from the any of the helpline or the counselor. That's very important. And what is finally it is about the responsibility and respect the individual about the body parts, bodies, and the sexually transferred. Already I mentioned about, and important about the refrain from the imposing sexual preferences on another. That's very important when you talk about the corresponding sexual responsibilities. And this is the act is there, rights of the person with disability act is there, and there also they have mentioned about disabilities with the decision making and what are the legal authorities. It is not only the sex education, the legal concern should be addressed properly. These are all the challenges are there when you're talking about the CNC in the child with adolescent with a disability. Cultural resistance may be there, misinformation, stereotype is there, and ostracic effects are there. Cognitive bias, avoiding negative information which can pass through, addressing intimate partner violence will be there. Government and NGOs should work together, which is cannot happen sometimes, and integrating in the curriculum. We talk in so many forums, but it is difficult because I'm working in this forum. So far, they are not started. A lot of 30 girls are there. It's not started. Maybe I should introduce to them. They're taking care of menstrual hygiene and other things. When it comes to sex education, I think I require Shilpa madam to create a model and give to us so that we'll start. Because this is the unique. We talk about adolescent sex education, not with the disability. I think these are all the challenges will be there that should be addressed. Finally, it is about importance of ongoing sexual education related to this disability and encouraging the continued lead support is important that helps in the driving the policy and the social challenges. So this is short topic I just mentioned about adolescent with sexual issues, sexuality, and sorry for the because of the time I had to run. But let us understand about what can be done under the leadership of Shilpa Desai Madam, so that let us have a protocol to address them out of the education, what are the personal hygiene, and when it comes to pregnancy, what can be done, any act can be there, or the legal issues can be addressed with a model. Thank you all. Thank you.
Thank you. Thank you very much. So that was Dr. Somshekhar sir from Ramaya Medical College. Thank you so much for a lovely presentation and giving so much insight into adolescent sexuality. This can be a topic in itself and so much can be spoken about it. And just few words before I want MKC Nair sir to even comment on this. So the last few words that all of these cases that we discussed today in the panel discussion, and it was so unique, all of these cases give us such a different scenario where adolescents have such a heightened limbic system and they are so much prone to impulsive decisions and even vulnerable to addictions and all of the risk taking behaviors, just like any other adolescent, but so much more because there is some neurodevelopmental condition and neurodiversity involved. And because of all of these, adolescents with neurodevelopmental disorders have low self-worth. They are going through shame, blame, guilt, anxiety, depression, and maybe oppositional behaviors also, which parents are not able to understand. and also they are going through a very difficult time with peer acceptance, and also they don't know how to follow the societal norms. So it's very important, and as Dr. Samir mentioned in the beginning, that we have to start from the beginning. We cannot skip some steps and start teaching from the adolescent age. So what we are really managing in adolescence is not just a disorder, but we are managing the developing brain and also a very demanding social environment at the same time. So let us shift from a diagnosed based thinking to developmental, contextual, and system based understanding. As Dr. Samir also said, let's not label too much and let's not only manage the symptoms. Thank you so much, everybody, for your patience listening. And I hand over to MKC Nair, sir, for the expert comments, sir.
So good evening. I think it was a wonderful 2.5 hours. And there's only 5 more minutes left, 5 to 10 minutes left for 2.5 hours. So I will not make it long, just 3 comments. Number 1, the neurodevelopment chapter and AHA coming together is a wonderful move, and thank the chairperson for that. Excellent move, because we both talk about the same thing, but maybe at little different age. That's all. One in childhood, other one in adolescent. The second point is all the talks, whether it is ASD, ADHD, intellectual disability, all were excellent, to the point and matter of fact, and has given some latest information. But particularly, I want to emphasize one point on that: outside one standard deviation. When you talked about the intellectual curve, that we showed about one thing. I think this is something we should take very carefully, because it is better to be retarded than get into this in-between group. And especially when you showed that boy, so handsome, good looking, and he's so, nobody can say that he has some problem. So neither the parents nor the teachers understand that he has a problem. So this poor child is in a much worse situation than the normal child or the even intellectually disabled child. So it is like that premature, we used to call it as preterm, late preterm. We used to call it near term has replaced by late preterm. Something like that, I think we need to work. The last talk of course, is very important, because it is it's very it is so difficult to give this talk, because it is a complex subject. I will only say 2-3 points on that. One, the parents have to be made comfortable talking about this. Most parents are so uncomfortable with the whole thing, they feel shy, they get into all that. And when Tutaja Sab is there, actually take his help, how to handle all the sexuality issues. I think he must have given 1,000 talk on sexuality. So that is a one great idea that we can do. The problem is, when the parents are happy or they are comfortable about it, they will say, for example, masturbation, for example. When they do in public, all you have to do is they pass urine in the toilet, they pass stool in the toilet. Why not this also in the toilet? Their problem is we all have that social inhibition, whereas these children don't have. That's a key point that we need to. But one particular group which Sir Somu has not mentioned, that is about the hearing impaired children. They are the worst. We had some great experience. Somebody was doing a PhD on that in a hearing impaired institution, not just left alone like thing, school, for example, or college, where they are doing hearing impaired. You will be surprised to know their knowledge about this matter is so poor, so poor. So we wondered, why is it that the girl is already 18, 20 and she doesn't know the basic? What is the problem? We all learn from something we heard from here, something we heard from this place, like that. Unfortunately, the world is silent for them. They don't hear anything. If you are visually impaired, you are better off, because even if you don't see anything, you hear enough from every source. So hearing impaired, I think, sir, that is one point. Next time when you talk about it, specifically focus on the hearing impaired, because they have no chance of getting any information. So what they did was, I was giving the talk for the normal children, and then the hearing impaired teacher will convert it into sign language and teach. So that may be a one opportunity we can do. I think excellent session. Everybody has done so well, and thank you all very much. Even Tuteja sir was there. Everybody was there. I just missing CP Bansal. Yesterday also I talked to him. You know that his family has some problem, serious problem. So we are missing him. We pray for her health. That's all I can say. Thank you, sir.
Thank you, sir. Thank you.
Thank you, sir.
Thank you.
Sir,
so
Arvind,
much.
sir,
Thank you so much.
Arvind Samant, sir, you are not smile at all. We don't go without seeing your smile.
Sir Savan, sir.
Let's see one smile from you, and then we will go. Okay, now it's a good smile. That is a good smile. Okay, then.
Thank you.
Thank you,
Good
sir.
night,
Good night,
everybody.
sir.
Thank you, everybody. Thank you.
Good night, sir.
Thank you, sir.
So before we end, thank you so much to all the speakers, all the participants. It is my pleasure to invite Dr. Arvind Sawant, who is one of our very senior executive body members of the Adolescent Health Academy, to propose the vote of thanks.
Very good. Very good.
Dr.
Before
Sawant?
that, I would like to thank personally to all of you for those excellent interactive talks. I think all the choice of the cases and the narration, how everything was so, there was a variety of topics which could cover. Dr. Somasekhar's talk was kind of an appetizer. We need to learn a lot about it. So this is just
Dr. Sawant, can you unmute yourself? I think so you're muted.
Thank you. Should I start?
Yes, please.
Thank you. Thank you, Dr. Shamik. It's really first of its kind to organize inter-specialty chapter webinar series. I congratulate Dr. Sushma Desai ma'am and for her thought and vision to organize such a great webinar, such a nice webinar, very informative and very knowledgeable. With the help of our secretary, Dr. Dynamics Secretary Dr. Shamik Ghosh. It's a very good webinar, and I am really thankful on behalf of our Central AHA Academy to Dr. MKC Nair sir for his experience, for his knowledge, sharing his knowledge every time. And I am admirer of you, sir. Always, I hear you so many times, and I am thankful to you and to Dr. Tuteja also that he has given full time to this webinar. And to all the experts of neurodevelopmental chapter also that they have given their full support and full knowledge to share their experiences also. I am really thankful to my dear friend Dr. Samir Dalwai that he has so I hear you. I think on this chapter I heard you for second or third time. But every time I am thinking that I am learning so many things from you. But your last one sentence is it is very important for all the ASD patient that for importance of the social engagement or human engagement and contact always interacting with those children are very important. This is the good message, and thanks to all the panelists, moderator Dr. Chaya Prasad madam, Dr. Shivraman, Swati Ghate madam, Dr. Navina Karthik and Dr. Soma Shekhar. Very good excellent cases they have all presented with good information and good knowledge. This is a multidisciplinary insights, practical clinical perspectives with good cases presentation and expert guidance for adolescents we have received today. It's very good, and we hope that we'll organize such type of sessions more in the coming future. And I am really thankful to Nair sir for his सर आपका बहुत बहुत धन्यवाद, नमस्कार. Thank you everyone for giving such. It's really 2.5 hours we have. Thank you everyone.
Thank you, sir. Thank you, everyone. So very good night. And before I sign off, my banner behind me shows the National Adolescon. So those of you who haven't registered as yet for this flagship event at Jaipur on the 27th to the 29th of November, please do so at the earliest. We would love to have all of you who have joined offline at Jaipur. Thank you so much. Good night.
Good night. Good night.
Hope
Good
to
night.
see all of you again.
Night.
Namaskar.
Good night.
Everybody. Thank you.
Good night, sir.
Good night.